Morning, Simone.
Hi Jeff, how you going?
Very well. And you?
Oh, I'm okay. I'm glad it's Friday. Having some technological issues with our work computer. Very frustrating.
Yeah. So where do you work?
Melbourne Vet Specialist Centre.
Oh, okay. Right.
But our technology is a piece of crap.
It's all what, sorry?
It's a piece of crap. No, I'm just feeling particularly incensed. I haven't been able to log in from home for 3 days, so I haven't been able to do any work at home. And then this morning, I can't even log in here in the building. Oh,
Oh. Um, I once saw a thing that was to err is human, but to really foul it up, you need a computer.
100%. Sometimes I just long for the days of paper notes. Yeah.
Yeah, so there's a lot to be said for pen and paper on under certain occasions.
Yes, I'm a big fan. I'm a big fan of, I'm a big fan of pen and paper.
Morning, Anna.
Morning. How you going?
Very well. And you?
Very well.
Morning, everyone.
Morning. It was nice to see you in the college seminar, Simone.
Oh, yes. Just getting
Yeah.
prepared for 20 years. So, it's all good.
Sorry, getting
Just
what?
getting prepared for something in 20 years' time. It's all good.
Yeah. It'll come up real fast.
Oh, gosh.
Oh dear. Where are you up to again?
I mean,
First-
technically, I'm in the second year of my residency.
Yeah.
Yeah.
That's not far away.
When I start the morning and I can't even get the computer to turn on, it just feels like a long.
It's just, I think that's what happens when you get specialized, is that you get bad at the other stuff and you just need to employ someone to turn your computer on for you.
Yesterday, I tried to get someone to fix the situation. Today, it's not fixed. It's worse. Oh.
So annoying.
You can find a 10-year-old to help you.
Yes, who needs to bring their
that is-
kid to work. Yes.
Yeah.
But we've been
Proud
told that IT, because we're kind of Green Cross, they manage our IT because we're half
Yeah.
Green Cross. And then
Yeah.
they're all in Queensland. So there's no IT for the next 2 days because they're all bunkered down for a cyclone. So
Yeah,
that's
of
great.
course. Yeah.
Good.
Yep.
Yeah. Is anyone here in Queensland? No, you guys are in Sydney.
Sydney, Canberra, I think.
And I'm in Geelong.
Oh, Geelong, that's right.
We're all safe. We're safe down here, Pooja.
Yeah. Feels a bit
Quite safe. Okay, let's get started. I'm just going to start by saying I find toxicology hard to treat. Hard to teach, also hard to treat. Because it's just like a list of like different things, right? And how they impact the body and stuff. So I just wanted to start by asking if anybody's got anything specific that they want to learn about toxicology. No.
Nothing,
No.
nothing in particular, and everything in general.
Everything, yeah. Please, let's learn everything. So I guess the things that I find interesting about it are the ways that the liver processes toxins, in particular, and how different toxins impact. So I find hepatotoxicity probably the most interesting. And I think it's a really good model because the detoxification systems in the liver are replicated in other systems, and like particularly like hematologic toxins and things can be impacted by the same things. So I want to kind of, while we're doing the Toxicology 101, which is today, want to just go over those kind of basic physiology stuffs. And then next fortnight, we're going through specific like kind of case-based, like a patient presents with a neurotoxicosis. Let's kind of work out like whether it's an excitatory one, whether it's an inhibitory one, and go through stuff like that, if that's all right. And then I guess we should probably do like different mechanisms of decontamination as well, just because that's like often they're presented known to have ingested something, and that's not really covered in any of the individual cases that we'll talk about. So let's start with decontamination. So say When would you think about using decontamination in a intoxication case?
Now, this is an interesting question because some time ago, I saw some work by a couple of, I think, American toxicologists saying that vomiting is not an effective method of decontamination and use activated charcoal. Well, I find that hard to believe because as far as I was concerned, like with snail baits, vomiting was diagnostic. If it was green, it was methaldehyde. If it was blue, it was a carbamate.
Yeah, for sure. And we've had cases of Brunfelsia, the yesterday, today, and tomorrow, and the seeds come through as well, like come out in the vomit, and that can be diagnostic. So when would you say, okay, let's induce vomiting?
Well, I think if there's a known toxin ingestion recently, and I have a couple of hours as my recently, I don't know how scientific that is, and the dog is clinically still 99% fine, that's when I
so 30 to 90 minutes in theory is you want to do induce emesis within 30 to 90 minutes of like ingestion. But then
what if you get there before 30 minutes? What's wrong with that?
Oh no, like in some toxicities, there's no point doing it after 30 minutes.
Oh, I see what you mean.
Absorb really fast, like particularly if they've got mechanical absorption.
Like drugs, like if they've got into
medication. Exactly. But some toxins, like 90 minutes, you'll still get the majority of it because it's absorbed from the lower intestine or something like that.
Chocolate, I think you can do even like 4 to 6 hours after.
Well, I just if the patient's conscious and there's no contraindication for it, I would normally just say, let's just do it. And we know that that's not going to solve the problem. There's going to be some already absorbed and there's going to be some that doesn't come up when we induce vomiting. So we're still going to
get a lower dose. It might be the difference between dying and not dying.
Yeah, exactly. Yeah, absolutely. So I'm going to disagree with the people that Jeff heard speaking. I don't think we should rely on it exclusively, but I think it's part of the decontamination process. How do we make dogs vomit?
Apomorphine.
Yeah, easy peasy, right?
Is this a trick question? Like, what is the answer?
No, now's the trick question. How do you make cats vomit?
You give them Domitol, cross your fingers. That's what I do.
Yeah, great.
But the ones you want to vomit won't. The ones you don't want to vomit will always vomit.
Or xylazine. You can also, if you have in practice, use xylazine.
Yeah, excellent. I do get a little bit nervous about xylazine because you're sedating them while you're inducing vomiting. They just the swallow reflex.
I think, I have reversed xylazine before with atipamezole, and it does mostly work.
Yeah.
Oh, cool. Okay. Great. Yeah. Okay, excellent. Why doesn't apomorphine work consistently in cats?
It's the dopamine receptor thing, I think.
What's that thing?
I have to get into my recess.
Just go through the archives quick. What is the center in the brain that's impacted by apomorphine? Or that induces vomiting?
As in the vomiting center, is that what you mean?
Yeah, exactly. And what center feeds into that?
CRTZ, I think it is.
Yes. Chemoreceptor zone. So usually when it's a drug inducing vomiting, it goes via the chemoreceptors and that triggers the emetic center. So if we're using apomorphine to trigger vomiting, it's going via the CRTZ, and we're going to activate the dopamine receptors, which dogs have, and cats don't. What receptors do cats have?
Alpha 2.
Good. Excellent. That's why xylazine works and modafinil works. Yeah. Has anybody ever seen anybody spin cats around to make them vomit?
I have done that.
You have done that?
And I felt dizzy and the cat hasn't bloody vomited.
I haven't done it. I'm worried that it's a bit too mean.
I know, it makes me a little bit irked, but then also leaving them with a toxin in their stomach, yeah. It's
Luckily,
not,
cats.
Well, I
love
did
stuff.
it gently. I sat on the chair and spun the chair around and then gave up.
I
You
would
made
love
yourself. You made yourself feel nauseous as well.
Yeah. I was at a friend's house and her daughter was just spinning around the other day and we were both going, woo, woo. And eventually she stops and goes, I'm so busy. I'm so busy. It's so cute. Okay, we're off topic already. Sorry. So that's the first step in decontamination is inducing emesis. Which toxin ingestions would you not want to induce emesis in?
Anything
Anything
caustic?
Excellent. Yeah. And like the petroleum kind of products were mentioned specifically as well, but I think that's because of their causticness.
What was the first one? Petroleum products, and what was the other?
Anything caustic, anything that's like
yeah.
going to burn on the way in or out. Yeah. What other methods of decontamination other than emesis do we have?
Lavage, gastric
Which
lavage,
Yeah.
and enema on the other
Emma?
end.
Yep. Perfect. Gastric lavage, does it, is there evidence based to say that it's associated with more positive outcomes?
I don't think so.
No,
Mhm.
it may
Well,
help some patients, but it's got such a high incidence of aspiration that it actually is associated with quite significant morbidity. So most clinicians are not recommending gastric lavage now.
Oh, really?
But then what do you do in cases where you can't induce emesis because of the fact that either the animal is already vomiting quite a bit or is like, already started to tremor or has had a seizure, then you can't really induce vomiting.
Yeah. There's still the recommendation is don't gastric lavage. I think there's so much like logic to doing gastric lavage, like it makes so much sense. But the science,
I do wonder how effective it is. Like, how much do you actually get out? I don't know.
That's the thing, actually. Yeah.
When I've done it, like I did it quite a lot early in my career because I worked in the country and dogs eat all sorts of stupid shit. And it was always such a frustrating.
Yeah.
Yeah.
Yeah, it's not very rewarding and it's very time consuming. And like
The dog gets cold. We
like,
had so many dogs get so fucking cold. Oh my God.
yeah. And like the changes, like where we talk about where the risk of aspiration pneumonia is under GA, it's during movement, isn't it? It's like when patients are being like moved from the surgery table to the x-ray table and stuff like that. Gastric lavage, you're often rolling them around, you're like elevating the head, then you're dropping the head, then you're elevating the head and you're dropping the head. It's like there's so many, even if you're super responsible, there's so many opportunities for that ET tube to become displaced. So many opportunities for the gastric tube to go down the wrong way. Like it's just fraught with danger, in my opinion. And not just in my opinion, based on the evidence. And it's got good logical sense, but realistically doesn't improve outcomes, and therefore do some reading in case the papers come out to say that it does improve outcomes and with a methodology that's safe. But my recommendation is to avoid.
Yeah, most tubes don't have a big enough orifice to get enough stuff out, really.
Exactly. Yeah.
It's like chunky rat bait or something.
Yeah.
No, maybe.
All right. What other decontamination methods are there?
Charcoal.
Charcoal.
Do we have cholestyramine in? I've never used it. I just know it in head like you can, but I've never actually seen anybody use it or used it here.
Yeah, I haven't seen anybody use it or used it either. I've looked up whether we can get it for dogs with, I want to say
Bile acid diarrhea.
Diarrhea, exactly. And I think it's available.
I'm pretty sure you can. Yeah, I'm sure Darren's used it. So yes, I think you can, but I haven't used it for detoxification.
Yeah. What situations would you use cholestyramine in? What sort of toxicities?
You can use it for like NSAIDs and anything like, because it's a resin that binds to bile. So anything
Yeah.
with them. So that's
Anything that has enterohepatic
hepatic circulation.
Great. Excellent. So let's just review that. Cholestyramine works by binding to bile and keeping it in the intestine. So it stops reabsorption of bile acids from the intestine. And we know, obviously we all know, bile acids get absorbed from the intestines up the portal system, back into the liver and recirculated out through the bile. So if anything's bound to bile, we get this like first phase of absorption, goes through the hepatocytes, sometimes gets modified to a metabolite, then comes out in the bile, then gets absorbed again, then comes out in the bile, then gets absorbed again. So you might give charcoal or something like that first pass, and that goes through and binds to most of it, but the toxin that's been absorbed and gets excreted again is going to be coming into the intestine after your charcoal, and it's going to be active again, if that makes sense. So in those situations, you want to be giving repeat doses of charcoal. In most situations, you want to be giving repeat doses of charcoal to make sure that you're capturing that recirculation effect. But where cholestyramine is nice is that it stops it being absorbed from the intestine in the first place, or captures it when it comes back out if you've kind of administered it later. And it stops it being reabsorbed and from participating in that ongoing circulation. Does that make
So
sense?
it's kind of an alternative to repeat doses of charcoal.
Not really. It's probably an adjunct too.
Okay.
So probably use them together. It's quite specific, the type of toxins that bind to bile.
Mm-hmm.
Only calciferol is another one, vitamin D.
That's a good one, I think. Yeah, to know about. Sago palms as well, and blue-green algae, and NSAIDs, as you said.
When I was doing my residency, we were told we had to use activated charcoal, which we did via stomach tube. Now, the clinic, the vets all had to wear white coats and white trousers.
Yeah.
White trousers, wow.
And they didn't stay white very long.
That's a bold choice. I guess you can bleach it.
Yeah. But nearly always the dogs would vomit.
Yeah. Yeah. Oh yeah, and that's so dangerous, isn't it?
Well, if it's a proper vomit, it's not too bad because of the reflex that's set up to protect the airways.
If the reflex are intact.
Well,
Yes, well, so long as they're properly awake, if you've just done it via tube.
Yeah.
But even giving conscious when they are really struggling, especially Frenchies, I've had this experience during Easter or things like that. You know, they come in hordes, chocolate toxicity, and you're wanting to give charcoal. With Frenchies, I always have my heart in my mouth because I'm like, oh, if they aspirate, I've just created another issue.
Yes. Yeah. Exactly. I don't know I mean, obviously the best way to administer it is just in a slurry that they eat. It's something delicious that they eat themselves. But so often these patients aren't.
Not wanting to eat.
Yeah.
Panting away to glory, and it's like, oh, just eat and go home. Leave me alone.
Yeah. Yeah. And syringing into their mouth is so dangerous as well. What is in most of the charcoals that we can buy today, there's an additive in it. What is it?
Sorbitol.
Yes. Why?
Oh, I don't actually know why it's in there.
And it's only to be given once with sorbitol, but yeah, why? Can't remember now.
I think it's a osmotic cathartic, isn't it?
Yes, exactly. So you give the charcoal, it binds to the toxin, and then it's whooshed out the other end. So it's an osmotic agent, draws fluid into the intestinal tract and helps flush it through. So you don't want to give that again when you're giving your repeat doses of charcoal, because the dogs get really dehydrated if they are being given repeated doses, and you've already sped up transit time. You don't need to do that over and over again. There's a risk with sorbitol, particularly repeat doses, that they can get quite hypernatremic quite quickly. Hypernatremic just from dehydration, just like massive fluid shifts. And that's then going to impact the consciousness, and it's going to make it hard for you to assess whether there is evidence of toxicity and stuff. So it's something that recommendation is that these dogs are on fluids while they're getting charcoal decontamination. That's all. Oh, so they're all the kind of like, I just ate something naughty decontaminations. What about when a dog's just like full-blown in toxicity, you have no idea what they got access to? What other decontaminations can we use that aren't gastrointestinal?
Intravenous lipid.
Good. What situations would we use that in?
When
I mean, I think if you,
lipophilic medications, if we know what the toxicity is and if it's lipophilic, then you can use intravenous
Good.
analgesic.
Yeah. So if it's lipophilic, the idea is that we're keeping that toxin in the bloodstream with the lipid, bound to the lipid, which is going to allow it to be processed and excreted faster, rather than that going into the animal's lipid stores and then being causing more prolonged exposure.
Mhm.
Good old fluid therapy.
Sorry.
I said good old fluid therapy.
Good old
Fluids.
Yeah,
I don't know
exactly.
if there's
Yeah.
evidence now for it or against it, but I think it still helps, doesn't it? Like,
It depends on the toxicity. Yeah. And the patient, and like if you've got a patient that needs to be monitored in hospital and they're going to get dehydrated because they're nervous and they're not eating and drinking well, then definitely you need to be on fluids. But if you've got a patient that's like a Labrador and it's like, hey, let's have a drink, they're probably all right. But yeah, and obviously if they need to be sedated for any reason, or like they're on medications that might suppress their ability to manage their own hydration, then lipid, what sort of toxicities did we say? Anything lipid bound, basically.
yeah, lipophilic agents.
Yeah. So I think non-steroidals are one of them. THC for sure.
Oh yeah.
And ivermectin,
Yeah.
the most common ones. So we used to use this when we used permethrin in dogs for ticks, and people would put it on their cats.
Oh.
Remember those days? Yeah, so we don't use it very often. I haven't seen it used very often anymore, but then again, I'm not in an emergency clinic.
A vague memory of sort of talk of acidifying or alkalizing the urine, depending on the toxin, but I don't think it's a very big front runner, because it's lost in the sands of time, unfortunately, somewhere in the back of my semi-functioning brain.
In the archives, way back there. I'm amazed at what comes out of the archive sometimes, but I think it's like all the song lyrics that were popular songs when I was a teenager, they're all in there still. I think that alkalinizing, because you probably used to see ethylene glycol toxicity and calcium oxalate, like plants with calcium oxalates in them. And those ones you want to decrease the calcium formation in the kidneys. So you want to alter pH in kidneys, I would imagine, to a alkaline state. But we don't see those toxicities very often anymore.
Most of the domestic plants are in that category.
They contain calcium oxalates. Okay. Yeah, right.
I did a talk in Adelaide a long time ago, and I went round the nurseries and looked to see what they had, and the majority of them were in that category.
Interesting.
Again, it's lost. The brain is not producing it for me. The other thing was they all had wandering dew, but they all said, "Yeah, but by all means photograph it, but you didn't see it here."
Oh yeah, yeah, definitely. We're not labeling that one. So interestingly, one of the decontamination things we didn't talk about in a gastrointestinal perspective is plants that contain calcium oxalates, because I was like, I don't know that that's common anymore. But you can give them milk, because the calcium in milk binds to the oxalates and stops them from being absorbed from the gastrointestinal tract.
Oh.
So instead of inducing vomiting, or after inducing vomiting, assuming that there's still some plant material in there, because we know that amexistone brings up 40 to 60% of what's in the stomach. If you give them 2 mils per kilo of milk, it binds the oxalates and decreases toxicity. That's cool. Good. Okay. So lipid emulsion is the main one I've seen used in Australia. Other decontamination processes that are reported in Edinger are plasma exchange, And I don't know if
I
anyone
think they have a machine
Does
at
it?
SASH, I'm pretty sure.
Ash does it.
do they? Cool.
I don't know
Okay.
how often they use it, but I think they have a machine.
Yeah, right. And then hemodialysis and charcoal hemoperfusion.
Charcoal.
Yeah, like they actually put charcoal into the blood.
Blood. Wow.
Yeah, yeah. Amazing. And that's used for ethylene glycol, ethanol, metaldehyde, THC, barbiturates, apparently.
We don't really have much ethylene glycol toxicity in Australia.
No.
No, I reckon I've seen it.
No,
No.
but what
Which
happens in
This
America?
is surprising. I don't know why though.
It's not cold enough.
Yeah,
Uh,
people don't use antifreeze. Yeah, I think there's small percentage of it in like some sort of car products. I think, but
Oh yeah.
once I tried to
drink
give the
it.
dog vodka, it died anyway.
Mm.
It's a diet anyway, did it?
Yeah.
Of kidney failure?
in North America, everybody has to winterize their car,
Mhm.
which changing the cooling water and putting more ethylene glycol in it. And of course, it's usually done at home, so it ends up all over the garage floor, which then the dog licks up.
Yeah.
And
Apparently,
Uh,
it's sweet. Apparently, it's sweet.
Yeah. Heard that too. Delicious.
so it's a geographic
Mm.
thing.
Yeah.
And the other interesting thing from America is chewing on electric cords and burning tongues and electrocuting themselves, because at the time anyway, the American cords weren't as well insulated as ours.
Oh, right. I'm still waiting for that to happen in my house. My dog's a cord chewer. I'm like, so I've got paranoia. Okay. So they're the main kind of decontamination principles. Anything else we want to cover with decontam?
Mhm.
Okay. So the next thing I want to move on to is liver, how the liver detoxifies different molecules essentially. And to start with, I want to just recognize that not all toxins are exogenous. So the liver is very good at detoxifying the waste products that come from the gastrointestinal tract. And that's its main job. So it's always working on that. And the reason I want to flag that is because we see reactive hepatitis quite commonly. And that's hepatitis secondary to endogenous toxins from the gastrointestinal tract, which are impacting the liver, impacting the health of the hepatocytes where they're coming in contact with them. So toxicity is not necessarily something that's ingested. It's something sometimes that we can work on by managing dysbiosis, microbiome, food, different kind of preservatives and stuff like that in food that might be causing some irritation to the liver.
So it's still kind of ingested.
That's a good point. Some of them, yeah.
Mm.
So the food, like a food additive,
Mm-hmm.
will impact. So this is where it gets very grey. I love this conversation. So a food product will alter the microbiome, which will alter the waste products and metabolites that are coming through, which will then alter liver, the impact on the liver.
Okay,
So-
but maybe it's actually the change in the microbiome that's doing it rather than the.
Yeah, and it's what's ingested which altered the microbiome, but is it actually an endogenous toxin or an exogenous toxin? Because if it's not, because we know that there's direct irritants that we ingest in food that cause gastrointestinal toxicity or inflammation, but are they? I don't think they're the toxicity, if that makes sense.
Yeah.
So the liver's doing this nonstop all the time. It's what it's designed for. How does it do it?
Is it that cytochrome 450 pathway?
Good. Tell me more.
I was going to say that's all I can tell.
And I'm done. Get in early and get out. This is so complicated, and I have to read it every single time I go to think about it and get it out logical in my brain. There's essentially 3 steps to it. So the first step is something that's been absorbed from the gastrointestinal tract hitting the hepatocyte, right? And then inside the hepatocyte, the goal is to transform whatever that thing is into a metabolite. So they just want to change it. And usually that's through reduction oxidation reactions, which are performed by the cytochrome P450 system. So that's just kind of a protein that essentially facilitates those reactions to change whatever it is that hit that hepatocyte into a different form. Now, that's not necessarily detoxification. Sometimes that metabolite is the toxin.
Mm.
So can you think of any examples of where something undergoes transformation and then that's the toxic part?
Is it the amino acetophen that gets converted to something and that's the metabolite that's toxic?
Yeah, exactly right.
I can't remember what it gets converted to.
Yeah. It's got 5 letters in it. NADPH or something like that.
Mm.
It's an acronym.
What was it? What was it you said, Pooja?
Acetaminophen gets
Paracetamol.
Panadol? Panadol. Yeah.
Paracetamol toxicity. Yeah.
Yep.
Yeah. So it's actually this pathway creates that toxicity by converting it into its active metabolite, which then causes the toxicity. So then it has to go through another change. Or there's other examples of that actually where the toxicity is the metabolite. And the main one to have in your mind, because it's clinically relevant, is it as a azathioprine.
Mm.
Those liver toxicity. So just have in the back of your mind that that's a drug that undergoes this kind of conversion and processing system and may get the toxicity may get amplified as it undergoes that conversion.
So would that be different to idiosyncratic? Because like some of the drugs can also cause an idiosyncratic toxicity. So would it be the same?
So whether the toxin is the whatever's absorbed or whether it's post metabolism, it could still cause idiosyncratic or dose dependent reactions. So tell me what the difference is between an idiosyncratic reaction and a dose dependent reaction.
I would think dose dependent would depend on the higher the dose, then you're going to have the toxicity. Idiosyncratic would be, it's like the recommended dose can be used in a specific species because there are some species differentiation as well. And then it's just randomly causing toxicity. And another time it may not do it, but then nobody wants to try another time.
Yeah, that's right. So an example of an idiosyncratic reaction would be like dopamine response to a sulfonamide or something like that, or a toxicity where like whatever the drug was or whatever the metabolite was created like an autoimmune reaction to it, where you get this profound diffuse inflammatory response to one antigen. And it's not dose dependent at all. Like the reaction is not going to be worse if you give more drug or less if you give less drug. It's just if that body sees that antigen or hapten as it is, if it's not actually an antigen, if it's a drug form, then you're going to get a really profound response. So sulfonamides are the most common like of those triggers. But as you said, there's breed dependent ones as well. And the important thing about those reactions are that you can't reduce the dose. So sometimes when we get like a non-steroidal induced mild hepatotoxicity, we might say, okay, well, let's just use a lower dose because the pain is such that it's impacting quality of life. If it's an idiosyncratic reaction, we won't be able to do that. So like immune-mediated drug reactions are probably the most common idiosyncratic. So it probably doesn't, like whether it happens before that biotransformation process, before the cytochrome P450 or after, it doesn't change whether it's idiosyncratic or dose dependent. So once we've got our metabolite, we've gone through that biotransformation process, what happens next? Have you heard of like what hepatoprotectants do we use for protecting the liver against toxicities or oxidant damage?
Dermamarin. So it's like methionine. Is that the main? It's the antioxidant in the liver.
Yeah, good. And how does that work?
Does it bind?
Yeah.
Has it got to do with glutamate or glutathione?
Glutathione, good.
Glutathione.
Yeah. Methionine, yeah. So it works as a thiol donor.
Hmm.
The next step after biotransformation, the next step is conjugation. So that metabolite binds to something that is going to allow it to be excreted. So it allows it to be passed into the bile and excreted and not absorbed back from the bile. So the two main pathways for conjugation are glutathione, binding to glutathione, or glucuronidation, glucuronic acid. So glucuronic acid or glutathione are the two things that we use, the animals, the species that we work in, use most commonly to bind to toxins.
So cats lack the glucuronidation.
Yeah.
Good. Yeah. So they've got half the capacity to reduce toxicity. So that explains why they're so vulnerable to certain hepatotoxins. Hepatotoxins and red cell toxins, similar pathways. So once those, we've got conjugation, the conjugation step, where does it go? It's still in the hepatocyte at this point.
Then it goes to the protein.
We'll say again.
Most of those things are excreted in bile, I think, aren't they?
Absolutely. How do they get out of the hepatocyte?
To the biliary system, right? It'll go to the portal vein.
Yeah, but they're trapped in there. Does anyone know what the channel is that gets them out of the hepatocyte? It's got clinical relevance. It's collies and MDR resistance. P glycoprotein efflux pumps.
Oh,
Are they familiar?
I mean, some way I heard of it, but it's not quite there.
It's deep in undercover in it. So you know the MDR dogs. What's the mechanism of their multi-drug resistance? Do you want me to tell you?
Yes, I don't know this in detail. Just know that they are.
So essentially they've got an abnormality of their P glycoprotein, which is just this channel in the membrane of hepatocytes and other cells in the body, which pumps drugs out of the cell. So that P glycoprotein is really important in the excretion phase of the hepatocytes. So if you've got an abnormality of the tunnel that those toxins need to get out of the cells from, then you're going to end up with accumulation of toxins within the cells and then more damage to the cells. And if you've got an excess of P glycoprotein channels, then your drugs are going to be less effective because they're going to stay in the cells very short term, and that pump's just going to pump them straight out. And the reason that's so clinically relevant, that's the mechanism of an MDR multi-drug resistance, because there's that all of the drugs are just being pumped out of the cells where they need to be. And that's one of the theories of why some dogs respond really well to pred with IBD and some dogs are not pred responsive with IBD. They think it's P glycoprotein related and it's just exposure time of the cells to the drugs basically. So it's a good channel to know about, have in the back of your mind, same as like having like a little bit of an idea of like the P450 cytochrome system. It sounds tricky, but actually all it does is just its job is changing things from one thing to another, usually by an oxidant reaction or a reduction reaction. So creates an oxidant damage in the process of doing that. And then it's just excreted in bile. Once it's bound like that to the glucuronic acid or glutathione, it just gets excreted in bile. The trouble is that we run out of glutathione and we run out of glucuronic acid. And that's when we start to get a backlog of these metabolites that can't get bound. And that's when we've all of a sudden got all of these metabolites and the oxidant, the free radicals that are created from oxidant reactions inside the cells accumulating and causing oxidant damage and cell death. And that's when we get our ALT going up. Was that too much information?
No, it's good. I don't know if it'll stay, but it's good.
I have to read it every time, but I find it interesting every time. So.
Mm.
I think it's just the start of something big, actually.
Yeah. So then what I find really interesting is how we can then, working backwards, we've got a patient with a hepatotoxicity or a hepatitis of some kind. We can sort of say what might have caused that by where we're seeing oxidant damage or damage to the cells. So when we look at hepatitis, have you kind of seen the centrilobular versus
Yes, periportal.
Yeah, exactly.
With
So-
copper, yes, because that's the differentiation to know whether it's copper, like
Versus-
genetic versus like it's excessive copper in the body or copper is not getting metabolized.
Yes, exactly right. Yeah. So we can use that same kind of principle in a hepatotoxin context. So for example, I'm going to actually do some arts and crafts.
So with this MDR one, Anna, because like these dogs, there's some drugs that they can't have. It's not all drugs. So then are we saying all the drugs that they can't have, it's because of the the glycoprotein? Is that because they're sensitive to some drugs, right? Like it's not all the drugs.
Yeah, that's right. It's the ones that use that pump to be excreted.
Use the pump for,
Not all of
okay,
them.
yeah.
Yeah.
Nice.
Yeah, it's so interesting. Oh, wow. That's rough. Sorry. Okay. So this is a picture of a hepatic lobule. And there's unfortunately, annoyingly, two different ways of drawing this. This is the way that makes the most sense in my head. So pretend I've drawn 3 dots on all of these corners of the hexagon. And in the middle, we've got our hepatic vein. And these 3 dots, what do they represent?
So one will be the Hepatic portal artery. vein, bile duct,
Yeah.
and then hepatic artery, is it?
And
Vein.
veins.
Portal vein, hepatic artery, bile duct.
Bile duct, yeah.
Yeah. And in the middle is the hepatic vein. So which direction is blood flowing from the portal system? Is it going towards the hepatic vein or is it going away from the hepatic vein?
No, towards the hepatic vein.
That's good. So I'm going to do red. Blood is flowing this way. Which way is bile flowing?
The opposite way.
Opposite way.
So it's flowing from the hepatocytes along the canaliculi up here to go into the bile duct, which is kind of the collecting system, and down into the biliary system. So we've got portal blood flowing this way, bile flowing this way. What about the hepatic artery? Where does the blood go? It's just kind of a trick. Just kind of everywhere. Yeah, exactly.
Yeah, because like isn't it like giving blood to the hepatocyte itself?
Yeah, exactly. How much of the blood supply to the liver comes from the hepatic artery?
Not much. Not much. 20% or something.
Yeah, 10 to 20%. How much is coming from the portal vein?
The rest.
The rest. Yeah, that's the only 2 sources of blood. But most of it's coming from the portal vein. So most of the blood coming from the liver is not well oxygenated. To the liver is not well oxygenated, is it? So these cells are vulnerable to oxidant damage because they're not getting a lot of oxygen already. So if we've got a hepatotoxin, so say a dog ingested, let me make something up quickly. Let's say a dog ingested an iron. It ate its own as iron tablets.
Oh yeah.
So that's going to be absorbed from the gastrointestinal tract, come up the portal system, and it's going to hit the hepatocytes around that portal vein here. And what does iron do when it in cells?
Doesn't it cause like are we talking about like hepatocytes? Or are we talking about red blood cells? Because it'll also do something to red blood cells.
All of the above. It actually the same mechanism for damage to red blood cells and hepatocytes.
Oxidative damage.
It's oxidative damage, exactly right. And the liver's like not well protected because it's already lacking a little bit of oxygen. So we're going to get necrosis of the cells where the iron hits it, essentially. So we're going to get zone 1 pattern of necrosis. So if we got iron, rusty colored, zone 1 damage. What about if we've got a okay, sorry, I'm going to reword. So given our hepatic artery is in this cluster, are the cells in zone 1, zone 2, or zone 3 most vulnerable to oxidant damage? Which
Well,
cells have
three is kind of furthest away.
good? Excellent. So if you've got a toxin that causes like more subtle oxidant damage, it's actually going to impact these cells more than these cells. But these cells are going to be better protected because they've got more oxygen.
So why does the iron affect those cells more then? Sorry.
Because it's oh, such a good question. It gets into those cells at a higher concentration.
Okay, so those cells just take it up first, and then
Yeah.
maybe the cells in zone 3 don't really get much iron.
Yes, that's exactly right. Yeah.
So what kind of toxin then would get to zone 3 in enough quantity to cause the oxidative damage?
Such a good question.
Sorry, I'm sorry.
No, it's fine. I don't want to, because I've kind of like,
No, I can look it up. I'll tell you next week.
okay. I can't think of a good example.
It's okay. Oh,
But there's like specific patterns, like the pathologist will see a hepatic biopsy and say, this looks like this toxicity, or this looks like an immune mediated reaction to a drug, like an idiosyncratic reaction or something, like based on its distribution.
Yeah.
Wish I knew more about this. Okay. So that's the end of the arts and crafts, I think.
We can look this up and then next week discuss it again.
Yeah.
Yeah.
I think
I'll
it's
do the reading,
important. It's an important thing. So we can look it up and then we can
Yes.
have a discussion.
I think we're going to do specific toxicities next week. So let's do a couple of different hepatotoxins. And if you've got
the
any
different kind of patterns.
yeah,
Yep.
exactly, like what we'd expect on I'm just going to make a note that that's what we see. We do. I think we should definitely do paracetamol because that's a good one. What about non-steroidals? That's one we see all the time.
Yeah.
And then let's do a idiosyncratic one like the sulfonamides. Cool. All right. So everyone can do the reading and each of you can take a section and I'll sit back and have a little holiday. I will also do the reading. Okay. So then where are we up to? That's basically how the liver kind of processes things, and those similar like glucuronidation pathways are what they use in red cells. But yeah, no, I need to read more about that before I expand on that at all. Oh, that's the other one we should do, xylitol. Oh, I got it. Sorry. Zone 1 damage happens when it's a contact toxicity. So where iron's probably a really bad example because iron causes oxidant damage specifically where it contacts cells. But like another like a hepatotoxic mushroom, for example, would cause hepatotoxic like loss around that zone 1 because it's a contact toxicity. Whereas
So
if
the toxin is directly toxic to the hepatocyte.
yes, exactly.
Okay. Okay.
So where the hepatotoxin causes oxidant damage, we tend to see zone 3.
Okay. All right. So iron was just, yeah. Okay. Yep.
Yeah, iron was a bad example because the contact toxicity is an oxidant damage, but it's not via that cytochrome P450 system.
Yes. Okay. All right. Thank you.
No worries. Phew. This looks familiar somewhere. So that's pretty much all I wanted to cover as far as like basics of toxicity. If we then think about, we've talked about the liver toxicities we want to cover. Has anybody got any other system toxicities that they want to see commonly and would like to discuss?
With neurotoxicosis, like one of the things I've always in my head, and even now I think about is, dogs that come in with corticosteroid tremor syndrome versus toxicosis. Like obviously history is important, but like there's only so much you can do with history, especially if owners don't give you proper history. And then it's like, oh, is it, because the signalment, it's usually young dogs that present in like, and also toxicity, like you normally say young dogs will eat things more easily. So it's always in my head, I'm thinking, what is the chance of this being a toxicity versus is this a corticosteroid responsive syndrome? And I think one of the things is with the latter, if while sleeping they are still, then it's more likely to be that. However, it's not always the case that they're sleeping. So how do you, like, it's always, I mean, there's whether then you're going to do something with regards to toxicity versus give them steroids, it's always in my head. I'm always like, oh, need to have a bit of a think about this as opposed to just knee-jerk reaction, do something and like just give some drugs and
and I don't think methocarbamol is contraindicated in either. So that has been my clinical approach for patients that aren't too severely affected. Like if they can still eat and drink and stuff, then I'll try some methocarbamol, support them with some fluids. And if they get better, it was a toxicity. If they don't, I give them some pred, basically. But then the ones that are severely affected, obviously you can't really just hold off on prednisone. Yeah.
What about 1080? Because the national parks have put baits around around here. That's a consideration.
Yeah.
And,
how does it work? What to expect if you see it?
Oh my God, aren't they just usually like dead on arrival? I don't know. That's the only experience I've ever had.
Pretty much.
The practice at Crookwell worked out a method of treating it, which is basically based on bicarbonate intravenously.
Yes.
Oh, interesting.
I've seen one case of that and was quite frightening, and I couldn't do anything about it.
Yeah, it's pretty confronting. It's a terrible toxicity.
Another one I've seen a lot of, but probably we won't see it much more because it's quite illegal now, and that's strychnine.
Strychnine, I've never seen.
There is a new toxin they're using nowadays, PAPP. I can't remember the full form of PAPP. Because like they're not using 1080, but they're using this PAPP as toxic baits.
For foxes. Yeah, I think I've heard of it too, for foxes.
Yeah. But then like dogs can, because if you have dogs that go on off leads and they can have it. I'm trying to recall now what is because I had read this up because thinking, oh, if do get a case.
Para-aminopropionone.
Yes.
And it's yellow. Yeah. For dingoes, foxes, and cats.
Yeah, right.
It works by converting normal hemoglobin to methemoglobin.
Yeah. So you have to have that on your.
Oh, interesting. I'm gonna look up. Are they using that? You don't know if they're using that in Sydney? That's an
I mean,
amazing.
it looks pretty. All the websites are Australian that comes up, so I think
I think
Yeah.
yeah, because that's how I
Mhm.
looked it up, because it was like, I can't remember now exactly why I looked it up, but then there
Mm.
was this thing and I was like, oh, need to be aware of this toxicity, because if it comes in, then we need to know.
yeah, there's a thing from the Vet Board of New South Wales, so it must be a thing. Yep.
Okay. Well, yeah, let's cover that one because if the vet board say we should know about it, then we should know about it.
Uh, the other thing would be, I don't know whether likely in Sydney, but phosphorus that's used for rodent control in grain silos, because one of the things to be well aware of is that it's an inhaled or can be an inhaled.
Oh, interesting.
So if you've got a dog that's poisoned with it, it's also a risk for the operators that are treating it.
And that's actually, it's an interesting like principle of decontamination is first ensure staff safety.
Mm.
It's not that many toxins that we can be exposed to that pose a risk to us, I think, once they've been ingested by an animal, but that's a really good point. Particularly with cardiorespiratory ones, we don't want to, or neuro ones, we don't want to mess around with them.
Marijuana and prescription drug toxicities will probably be more common in Sydney, I think.
Mm. I had the funniest. I had a bull terrier who ate, like the owners had made watermelon, poured vodka in a watermelon. You know how people used to do that, and then and the dog had eaten the whole watermelon. Was so drunk, so sad. Yeah, I guess recreational drug toxicities we're seeing not with increasing frequency, but we're detecting it with increasing frequency because we've got the drug tests. But they're usually like kind of neurotoxicities, which are quite distinctive, I would say. So I don't think they're worth covering. What about nephrotoxins?
Lilies and cats and but the recommendations there have changed a little bit now. So
Oh, for which ones?
Lily,
Lilies, yeah.
like in the past, we used to just like give them fluids for 72 hours. Now they're saying, even same thing with grape, they're saying you don't have to do that in dogs.
So I think that's actually a good topic. Let's do lilies and grapes, like decontamination protocols and like what's new, what's up to date.
Heavy metals heavy metals are renal toxic, amongst other things.
Amongst other things. So they're an interesting one as far as the oxidant damage kind of pathways that we were talking about, like the iron one. We don't see them very often anymore though.
No.
I think, yeah, heavy metals are quite
like-
restricted in what uses.
Like lead is always on the list, but so far
Yeah.
never seen it.
I did have one, but I can't remember what the context was.
It's common in birds, chewing
Yeah.
in galvanized cages.
Yeah. Oh, the lead dog I had was a old like Federation house, and they were sanding back the door frames, and the dust was in the water bowl.
But something like lead will do multiple things, right? Like you would have evidence of it in hematologically as well. Like it wouldn't just be kidney or liver.
Yeah, that's
Yeah.
right. Logical hematology. It's the great pretender, like
Yeah.
Addison is.
What do we see on our smear review? Red cells,
Heinz bodies.
antibodies, and basophilic stippling.
I don't know if I know how to recognize that. I should look that up.
I definitely wouldn't recognize that as I just send it to the lab.
That's why you send it for interpreted every time.
Yes.
Exactly right. Yeah.
It's also possible in inner city areas that are on busy roads.
Oh yeah.
I know
Yeah.
case they bought a house and the previous owners had sanded all the lead paint and buried it in the backyard. Kids are playing in the backyard.
Well, just from the petrol, like the soil in Sydney, in inner Sydney, has dangerous levels of lead in it. Like they recommend importing soil if you're growing a garden, like edible plants in your garden. They recommend importing soil to grow them in. It's quite high, yeah. So I guess if you've got a dog with pica and eating soil, like maybe that's
Yeah.
yeah. but there's probably something else going on other than the lead toxicity.
Lots of kids eat soil. I feel like that's quite concerning.
Yeah. Yeah, absolutely. It's quite concerning. I would be really worried about that. Apparently they were using lead paint up until the 70s. So it's not that like we're thing like Federation houses, blah, 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 but actually that most houses that people live in particular are
I think
built in the 70s.
73, I think it was taken out.
Yeah. It's quite recent that there could be like if people are sanding back or next to neighbours, even if there's dust and it's falling in the dog's water bowl, the water bowl's outside and stuff. But yeah, probably not common enough to warrant like more detailed conversation. I reckon we stick with renal, lilies and grapes, neurotramotoxins and the PAPP. And then liver, we'll do paracetamol non-steroidals, and we'll do renal in non-steroidals as well. And the TMS sulfamides. Cool.
Okay.
All right. We'll see you in a fortnight.
Thanks, Anna. Thanks, guys.
Anna. Have a good day, everyone.
Have a good
You
day.
too.